Vanakkam. We are all doing flaps for reconstruction of hand defects. Small defects, large defects, defects involving multiple fingers, and so many other indications. But the flaps that we do, whether free flaps or advancement flaps, the groin flap or the cross finger flap, how and when did they evolve? When I looked up this topic, I came across an amazing article written by Fang and Chung about the evolution of flap reconstruction in the hand. I thought I would share with you the glorious history of flap reconstruction in the hand through the ancient period, the Dark Ages, the Industrial Revolution, the World Wars, and the modern age. It's actually going to be pretty interesting because we'll be seeing different generations of intrinsic hand flaps and different generations of free flaps used in hand reconstruction. Shall we get on with it?
Bear in mind that all the wonderful things you learn in your schools are the work of many generations. All this is put in your hands as your inheritance in order that you may receive it, honor it, add to it, and one day faithfully hand it over to your children. The key words here are the work of many generations. In trying to learn what has been the work of our previous generations in flap reconstruction in the upper extremity, I came across this article, An Evolutionary Perspective on the History of Flap Reconstruction in the Upper Extremity by Fang and Chung in the Hand Clinics in the year 2014. This video is an excerpt of this article. In this article, the evolution of flap reconstruction in the hand has been divided into 5 periods. The period from antiquity to the Industrial Revolution, from Industrial Revolution to World War I, the interwar period from World War I to World War II, the post-World War II period till the 1980s, and finally from 1990s to 2010s. The early antiquity period was characterized by the accumulation of anatomic knowledge and the initial principles of plastic surgery. 3 cultures played a major role: the Indian, Greek, and Roman cultures. Herophilus, around 250 years before Christ, described the first scientifically documented human cadaver dissections in Alexandria, Egypt. Galen, of the subsequent Roman culture, described muscular anatomy from a perspective that was based on both his interpretation of Herophilus's records and also his dissection of animals. These events formed some of the basis of surgical innovations that occurred in reconstructive surgery. But Sushruta of India, around 1000 to 800 years before Christ, described a regional pedicled flap for the nose in the Sushruta Samhita. During the Roman times, Celsus, around 25 AD, and Oribasius described random circulation pedicled flaps and local tissue rearrangements for the lips, nose, ears, and forehead. The Indian and Greek cultures developed in parallel and never combined to yield an even greater advancement. The collapse of the Roman Empire ushered in the Dark Ages of Europe. During the late Antiquity period, that is after the Dark Ages, rediscovery and progress in anatomy and plastic surgical techniques were seen. This happened mostly at the University of Bologna in Italy, where a group of anatomists rediscovered anatomy. Ugo Borgononi of Lucca and his son Theodoric of Servia conducted human cadaver dissections on executed criminals. The work of upper extremity anatomic depictions by the Renaissance scientist artists like Leonardo da Vinci and Belgian anatomist Andreas Vesalius working in Padua published Humana Corpora Fabrica, the accuracy and detail of which led him to become known as the reformer of anatomy. The invention of the printing press in around the 15th 16th century paved the way for further progress. William Harvey delineated the concept of arterial inflow and venous outflow in the extremities with his tourniquet experiment on the forearm and hand in his 1628 book, An Anatomical Study of the Motion of the Heart and of the Blood in Animals. Scientific journals were published from 1665 onwards. Based on these innovations, Gustavo Branca of Italy began using the loco-regional forehead flap technique of Sushruta for the nose. His son Antonio began using a distant flap reconstruction for the nose as harvested from the arm, which is the first documented use of the upper extremity as a donor site for flap reconstruction. Gaspar Tagliacozzi popularized this technique. Then the Industrial Revolution began. In this period, the first description of a definitive debridement by Pierre-Joseph Dassault was done, a French surgeon of the Napoleonic era, but this concept was still not accepted. It was not until World War I when debridement regained acceptance by the influence of the Belgian physician Antoine Depage. Dominique Jean Larrey introduced effective trauma triage with his so-called flying ambulance during the Napoleonic Wars. The general anesthetic revolution brought about by Crawford Long and later William G. Morton was an absolute prerequisite for the lengthy reconstructive surgeries that would evolve in the 20th century. Aseptic technique with carbolic acid and calcium chlorate, described by the United Kingdom's Sir Joseph Lister and Hungary's Ignaz Philipp Semmelweis, dramatically reduced infection rates and increased survival from trauma. ABO blood typing, discovered in 1901, yielded the life-saving tool of blood transfusions in 1907. Thus, mortality was reduced from 15% to 4.5% by the start of world wars, and surgeons at last had the option of pursuing limb salvage. But it was facial reconstruction procedures that established the principles of flap reconstruction in the upper extremity. In 1854, years after the first distant flap to the face, Hamilton performed the first distant flap to an extremity with his cross-leg flap. In 1862, Wood described with clear reference to the Tagliacozzian principle the first distant flap coverage for upper extremity defects with his axial pattern circulation groin flap for reconstruction of a cicatricial burn scar on the upper extremity of an 8-year-old girl. However, this technique did not become popular until half a century later. In 1897, Carl Nicoladoni applied the distant flap concept with a pedicled thoracoepigastric flap to cover a degloved thumb. Nicoladoni himself later further developed the distant flap concept with application to finger reconstruction in his description of a pedicled second toe to thumb transfer in 1900. In 1917, the crosshand flap substitution of ring finger for reconstruction of thumb was performed by Leonard Joyce, and in 1919, Albee developed an osteoplastic finger substitute that combined a bone graft with a distant flap. The period after the First World War brought about two important advances. It established principles of soft tissue reconstruction on the head and neck that were later used on the upper extremity, and the consequences of the unreconstructed upper extremities of the war convinced the medical community that hand surgery was a necessary specialty. After the First World War and before the Second World War, classified as the interwar period, brought about certain innovations. The invention of the operating microscope by Nylon in 1921 was one of them. The discovery of penicillin in 1928 and sulfonamide in 1935 brought on the era of antibiotics and reduced infections. This was the period when tubed pedicled flaps were also introduced by Vladimir Petrovich Filatov in 1916 and Harold Gillies in 1917. Hand trauma caused by the new age of electric machines and tools of industrial work during the interwar period drove the evolution of a first generation of intrinsic hand flaps, that is, techniques of reconstruction that resided within the limited surface area of the hand itself. It was in 1939 when hand surgery became a specialty due to the pioneering work of Sterling Bunnell. This paved the way for further innovations in hand reconstruction. After the World War came a lot of advances. The kidney transplant by Murray in 1954 was one of them. Learning to do vascular anastomosis was the main lesson that was learned. Learning to do microvascular anastomosis was just a step away in 1960 when Julius Jacobson and Suarez described microvascular anastomotic techniques. Studies of cutaneous vascular patterns in 1970s played a major role in further innovation in reconstructive hand surgery. In the 1950s, the second generation of intrinsic hand flaps were innovated, and after the 1960s, the third generation was innovated. We shall see more about the generations of intrinsic hand flaps a little later. Path-breaking surgical procedures changed the way that hand surgery developed. In 1962, the successful forearm replant by Malt and McCann, and in 1963, thumb revascularization by Kleinert and Kasdan, and toe to thumb transfers in China in 1965 and by Cobbett in 1968. And when revascularization and replantation could be done, could free flaps be far behind? After the 1990s, two factors enhanced the growth of reconstructive hand surgery: information revolution and evidence-based medicine. Karl Manchot had performed the first studies of the circulation in 1889, and in 1936 the French anatomist Michel Salmon, who was able to show in great detail much smaller vessels, paved the way for the foundation of the angiosome concept by Ian Taylor. By the second millennium, fourth generation of intrinsic hand flaps developed. Perforator flaps by Koshima were developed in 1989. The innovation of perforator flaps was a culmination of knowledge of anatomy, vascular supply, skill sets, and technical advancements. In 2003, Fu Chanwei and Samir Mardini introduced a freestyle technique of dissecting the vasculature of perforator flaps in a retrograde fashion, and the concept of freestyle perforator flaps came in. The partial hand transplant done by Dubernard in 1998 opened the floodgates for further reconstructions. As microsurgery grew, vascularized lymph node transfer by Shen in 2004 further showed the direction in which microvascular reconstruction developed. We have come across mentions of the different generations of intrinsic hand flaps. We shall see about this in detail. There were progressive generations of intrinsic flaps in the hand that were developed along with the reconstructions on the rest of the body. The article talks about four generations: the first generation, second generation, third generation, and the fourth generation. The first generation of intrinsic hand flaps developed due to the impact of war injuries, industrial trauma, and dissemination of medical literature. These were based on lessons learned from head and neck reconstruction in World War I. Gatewood introduced the first distant flap of the hand in 1926 with the thenar flap for index fingertip reconstruction. Edwin de Jong described bipedical advancement flaps for volar fingertip coverage in 1942 for factory-related injuries. Though Gurdon and Fang reported the cross-finger flap in 1950, it was Cronin who first performed these flaps in 1945 to treat injuries during World War II. Advancement and transposition flaps were performed in 1935 by Ettore Tranquilli, an Italian surgeon who described the use of the VY advancement flap on the volar fingertip. Jesendorfer of Germany with his lateral VY fingertip advancement in 1943, William Cutler of the United States with the bipedicled lateral VY advancement flaps were inspired by the work of Tranquilli. Similarly to the Atasoi flap, Venkataswamy flap and the Segmuller flaps. Dorsolateral transposition flaps on the fingers described by Levin in 1951 harnessed random patterned blood supply. The second generation of intrinsic hand flaps were characterized by axially patterned blood supply. They followed the same course of flap reconstruction of the face years earlier. The precursor to the first dorsal metacarpal artery flap was described by the German Hilgenfeldt in 1950. It was developed in parallel by William Littler and Erich Moberg in 1960s. Holwich, Guy Faucher and Jean-Bernard Braun modified this technique to the present form of the axial patterned FDMA flap. The similar analog flap, the flag flap, was further refined by Iselin and eventually Lister. Axial advancement flaps for sensate skin cover for fingertip injuries were developed by Houston in 1966 and Erdogan Atasoy in 1970. Harold Luders, Brijbhushan Joshi and P.J. Smith, among others, modified the design of the dorsal transposition flap of Levin to design axial pattern blood supply flaps. The third generation of intrinsic hand flaps developed during the 1970s and 1980s. These were characterized by pedicled island flaps with skeletonized axial blood supply. The heterodigital island flap strategies combined the pedicled re-innovation concepts of Moberg and Littler with the spare parts, that is the fillet flap reconstructive methods of Peacock. The previous generation's dorsal transposition flaps were developed into sensate homodigital island flaps by Joshi, and the thumb dorsal transposition flap was similarly developed into a homodigital island flap by Faux. This period of time also saw further modification of the cross-finger flap concept, producing the adipofacial cross-finger flap, which led to further homodigital use of the adipofacial turn-down flap. The fourth generation of intrinsic hand flaps has been the result of the information revolution, with unprecedented access to technical detail, which has been a major evolutionary influence in this era. Kawaba and Maruyama found that vascular islands and adipofacial flaps were viable when oriented on reversed flow on the fingers or on the palm. Other innovative flaps like the spiral flap, which resembles the Orticochio scalp flaps based on the unique axial blood supply of the hand, the Gigon flap, which harnesses an island pedicled based axial supply in a double VY advancement reminiscent of Atasoy's concept, the boomerang flaps, which combine the concepts of reverse flow and perforator flaps, and with advancements in technology, even smaller and more technically challenging island flaps based on the digital artery perforators have been categorized as fourth generation flaps. A description of reconstructive hand surgery is never complete without microsurgical concepts and microsurgical advancements. It is interesting to note that the evolution of the higher rungs of the reconstructive ladder in the upper extremity had progressed ahead of the development of the lower rungs. In other words, microvascular transfers to the upper extremity occurred before the development of pedicled, axially patterned fasciocutaneous, musculocutaneous and muscle flaps in the upper extremity. Microvascular reconstruction actually started with the first free flap transfer of segments of intestine to the head and neck region in 1964 by Yoshio Nakayama. Surgeons in China did the first extremity free flap transfer of microvascular toe to the thumb in 1965, but their work remained unknown. In 1968, Corbett performed the first publicized toe-to-hand transfer. In 1971, McLean and Bunke transferred an omental flap for resurfacing a skull defect. Daniel and Taylor accomplished the first microvascular extremity reconstruction by free transfer of a groin flap to the foot. Harry and colleagues of Japan consequently performed the first microvascular fasciocutaneous transfer in the upper extremity with a groin flap to the hand in 1973. The first free musculocutaneous transfers to the upper extremity were performed in 1976 by surgeons in China transferring pectoralis to the forearm. This remained unknown to the world until subsequent years. Ikuta and colleagues of Japan transferred gracilis to the forearm for treating Folkman ischemic contractures. Taylor et al. And Thamai introduced the fibular osteocutaneous and iliac osteocutaneous flaps in 1975 and 76 respectively. By 1979, these flaps were being used routinely in the upper extremity reconstruction. The upper extremity even evolved into a free flap donor site with a radial forearm flap performed by G. F. Yang of China in 1979. By the 1980s and 90s, free FDMA flap was introduced by Gunther German in 1995. Honda and colleagues and Tsai and colleagues first designed venous flow-through flaps for small defects of the hand in 1980s. These venous flaps have been used in both free and pedicled fashions, but they have remained less popular tools. Hallock introduced chimeric flaps, that is multiple different flaps harvested on the same source vessel in 1991, and these flaps have provided effective coverage for mangled upper extremities with composite tissue requirements. The first successful hand transplantation occurred in 1998 when Dubernard performed a partial hand transplant for the patient Clint Hallam. The most recent advances in hand reconstruction, the free perforator flaps described by Koshima, the free femoral medial condyle flap described by Doi, and the freestyle free flaps described by Samir Mardini and Fuchanwei in 2003. The future of hand reconstruction could be anything. It could be an answer to severe cicatricial burn scarring, disabling joint contracture, or end-stage mangled hand in the form of composite tissue allotransplantation, or a vascularized groin lymph node flap transfer with progressively smaller anastomotic targets using super microsurgical techniques. These will evolve more quickly because access to surgical technique and interchange of ideas have become well integrated. Future could also be in the form of many more innovations that we do not know about today. But innovations cannot happen in a vacuum. It's often inspired by the ideas and inventions of those who came before us. By studying the past and learning from the successes and failures of previous innovators, we can create new technologies that are even more advanced and impactful. So history plays a major role in inspiring innovation from the past to the future.
I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about the different aspects of hand surgery. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.